The bit where it becomes complex is that becomes pervasive, so it starts to affect every area of your life and affects how you cope with stress and your self-image. So how you look at yourself, your relationship with yourself, and your relationship with other people. So CPTSD stands for Complex Post-Traumatic Stress Disorder. People are more familiar with post-traumatic stress disorder. That's when you have a generally one-off trauma and it gives you quite a few symptoms where you're reliving that event. Complex PTSD is often when you've had multiple traumas that are often in a critical period of your life. So a lot of childhood or adolescent traumas, and they actually become more pervasive in your way of looking at the world and way of looking at yourself. And so that's what makes it complex as opposed to a regular PTSD. Typically we see it in a very critical period of your childhood or adolescence, and it might be adverse childhood events. So that can be all sorts of things from domestic abuse to not having adequate parenting. Say, for example, your parents have suffered from their own mental illness. Doesn't necessarily mean it's anyone's fault, just as a child you've not had that experience of being looked after. All the way through to kind of sexual abuse and kind of more typical traumas. There is some evidence, improving evidence, that actually babies can also experience trauma, and it can come out later in life, maybe as a complex PTSD or something that's not really fully understood because you don't really have full formed memories of it at the time. Yeah, absolutely. So to focus on the post-traumatic stress disorder symptoms first, because they're, I think, easier to understand. So you can relive the episodes, you can remember the episodes. So there's a difference between reliving it in terms of flashbacks and remembering them. The flashbacks really are reliving the event. And we think that's to do with time stamping. So because the traumatic things happened and your brain was so distressed at the time, the brain hasn't properly time stamped the memories, and so they come and play at the worst possible moments. So that's a true flashback where you really relive it and you're not able to work out that it was not happening to you right now. You're also very aware of threats, so we call that hypervigilance. You can be quite jumpy, you can have difficulty relaxing, especially at night. So people have really great difficulty going to sleep at night, and it's because they're constantly looking for threats. And you also have anxiety, so you can be very worried about leaving the house, for example. People can have like checking behaviours, making sure windows and doors are shut. They're the kind of core features. In addition, you have avoidance, where you're avoiding similar situations. So, for example, if you were assaulted on the street, for example, you might avoid that street. Or you might avoid smells or tastes or some slightly weird connections that are associated for you to those traumas. The bit where it becomes complex is that becomes pervasive, so it starts to affect every area of your life and affects how you cope with stress and your self-image. So how you look at yourself, your relationship with yourself, and your relationship with other people. And that can become disorder. And as you can imagine, that's very disruptive. So people can have very short-lived relationships, difficulty trusting people, thinking people are looking at them when they're going on the street, having very low self-esteem, and really can really reduce people's confidences. I think the most important thing to remember is once you've got a diagnosis, the label in itself can be helpful because it helps we'd say inform your narrative. So you know what's coming, you know it's a flashback, you know that you're going to be okay, and actually these things happen to you through no fault of your own. So it's not a self-blaming situation, these things happen. And then onward from that, you can do grounding techniques to help stay in the here and now rather than to kind of go off into the past. And they can be really a lot of things. So some people do square breathing. That's when you breathe in for 2 seconds, you hold it for 2 seconds and you release it for 2 seconds. And that can help ground you in the here and now. You can do mindful activities. So if you're getting very distressed, it's more easy to do more active mindful activities. So that might be going for a walk and feeling the pavement on your feet, or listening to the birds or something like that. Or you can do more passive or sedentary mindful activities, kind of meditation and that sort of thing. But I find with me that the more distressed you feel, the more difficult it is to engage in that. And the other thing you can do is very much tell somebody. So if you feel like you're going to have a panic attack or an anxiety attack and you feel that you are on the edge, get somebody who understands to sit with you. I think that's very valid. You might not want to explain yourself, and that's okay. You know, I feel very anxious. Do you mind sitting with me and chatting to me? I think that's a very, very reasonable thing to do. So some people, to manage those symptoms, can have coping strategies. We all have coping strategies to manage our distress. When the distress gets too much, you can have maladaptive coping strategies, and that can be things like thinking about suicide or self-harm, and we see that quite commonly in CPTSD. So I wouldn't say they're incorrect or correct coping strategies. The thing about coping strategies is everyone has them and everyone uses them. The problem with maladaptive ones is that they two problems with them. One is that they work, so they're quite effective at managing distress. The second part of it is they're not helping you in your adult life. So that's where it's maladaptive. It's not that it's wrong, it's just no longer serving a function in your life and actually sometimes causing problems. So a typical one would be self-harming. It is quite an effective way of managing distress for some people, but obviously it causes quite a lot of physical issues and also not managing your distress in the most appropriate way. So you could have more effective coping strategies to manage that. It's quite undifficult to unpick because the reason people do that is because it works for them. So we can do things like harm prevention. So you could do things that feel similar, have the same rush of endorphins, for example, as self-harm, but don't cause the physical damage. So things like that would be having a very thick elastic band around your wrist, for example. You can flick that. It causes a similar feeling of pain and allows you to be mindful and focus on that, but doesn't cause any harm. Some people also like to have their hand and put it in some ice or in the freezer. I find that can be helpful, but it's these episodes can happen out of the blue, so you want to have something that's accessible to you. And then all the way through, a lot of people use exercise as a coping strategy, for example. Yoga can be a coping strategy, talking to people. So you need to replace the ones that aren't serving you for ones that are serving you. Easier said than done. So when we're thinking about treating complex PTSD, I think it's very important that it's individual for the patients. However, we have three major categories that we like to think of. One would be biological, so that would be thinking of the kind of chemical imbalances in the brain. If you're suffering from a lot of anxiety related to your trauma, then medications can take the edge off. I would generally recommend a class of something called SSRIs, and they're very useful at treating trauma. They also can help with sleep, and a lot of people really struggle to relax and go to sleep because they have that hypervigilance. And we cannot underestimate the importance of good sleep. If you're not sleeping well, then you're not really able to engage in anything else. Medication has got a place. I take the view that it allows you to have the headspace to be able to engage in the psychological therapies, which is ultimately going to be the cure. So there are two different types of therapies. One is very focused on trauma and the other is very skills-based. The trauma therapy would be something called EMDR, which is a very strange therapy where you move your eyes in a particular way while reliving the most painful memories. And somehow that allows the brain to timestamp these memories appropriately. And even though you can still remember them, the level of distress about them is reduced. We don't understand why it works or how it works, but for some patients it is remarkably effective. Another way of looking at psychological therapy would be the skills-based work. That would be looking at the sort of maladaptive coping strategies and interpersonal relationships and improving those separate to the trauma. And it's horses for courses. Some patients really don't want to go back through the trauma, and I really understand that. And some people do, feel like that can of worms has already been opened and want to address it. The only thing I would say is constantly reliving your trauma, except for in a therapeutic, other than in EMDR, is not necessarily helpful for patients. So, for example, with my patients, I won't necessarily write in the clinical letters a detailed list of the trauma, for example, and that is because I don't want patients to reread that and re-traumatize that themselves. Doesn't mean I haven't listened, it just means that I don't want to go over it and over it and over it. Because that can cause problems in itself. So it's difficult to say about a generic patient, because the most important thing is that patient is well enough to be able to engage in desensitization work, essentially. So you want them to be stabilised, and there might be quite a bit of work to make somebody stable to be able to go through that process. The other thing is, do they need to? Some people might be avoiding, I don't know, something quite peculiar and specific that's very easy to cut out. Other people might really be affecting their level of function, like going outside, for example. And so what I'd recommend is, the way anxiety works is it rewards itself for leaving that situation. So you leave, you feel better, that encourages you to, next time you're in that situation, to leave and feel better. What you want to do is undo that and have some wins while you're there. So for example, very small changes, staying for a certain amount of time and then leaving, and allowing yourself to experience the anxiety but not becoming overwhelmed with it. Now, depending on the patient, those might be bigger steps or babyer steps, and it's about tailoring it to the individual. What you don't want to do is force yourself or someone to go into that environment and just sit there. It's called flooding, and it is incredibly distressing, and what you might do is prime somebody to be more distressed the next time that happens to them. So it's about small steps where you feel anxious, there is some small distress, but it's tolerable, and you do lots of techniques to try and make somebody feel less anxious in that situation.